I'm Dr. Anil Gudi, and I'm joined by Dr. Sachin Kulkarni. And today, the topic of discussion is what is the best drug to use in polycystic ovarian syndrome for IVF stimulation? For years, we have been discussing, is recombinant FSH the best drug to use? And maybe we have been influenced by how marketing as well as pharmacy discussions occurred, that because there was LH already high in PCOS, we should not be using HMG, and we should be using recombinant FSH as a treatment and as the best form of stimulation. Over the period of time, many of us have moved back to HMG, highly purified, and have been getting good results. Now, this has been tested over and over again on whether HMG would lower your success rates and whether it would be a bad drug to use. And many studies have at least given the same success rate as recombinant FSH. In recent times, there's been a slightly better, or I would say, a slightly tilt towards HMG as being the drug of choice in some cases of over responders. And there were two phase 2 and 3 trials which took place, the two RCTs, which showed a lower number of oocytes with HMG, a lower number of ovarian hyperstimulation, fewer interventions for ovarian hyperstimulation, and an increase in live birth rates. So a study was, we'll present a paper which showed this in a slightly different way. And what they said, let's look at a randomized, assessor blinded trial of highly purified HMG versus recombinant follicle stimulating hormone in high responders undergoing ICSI. Now, in the United States, many clinicians will use a combination of drugs, of HMG as well as recombinant FSH, and there has been no evidence to suggest that this treatment works. So let's look at the materials and methods. Again, a non-inferiority trial evaluate the efficacy and safety of highly purified HMG versus recombinant FSH, and it's called the MEGASET HR trial. The age group was between 21 to 35 years, with women who had irregular cycles, with an AMH of greater than and equal to 5 nanogram per ml. And what was not included was stage 3 to stage 4 endometriosis, recurrent miscarriage, history of poor response. The HMG used was Menopur, and the recombinant FSH was Gonal-f. The starting dose was 1 to 3 days. You start at 150, and a dose adjustment was done if needed from day 6. The maximum dose used was 300, and coasting was not allowed. 250 of HCG if a fresh transfer was given, and that's the ovitral injection, or if an agonist trigger was used, then 4 milligram of Luproi to reduce the risk of ovarian hyperstimulation, and elective freezing was done. PGTA was done as an independent marker for these transfers, and a single blastocyst was transferred. So if you have a look at the results, and I'll first go on to the duration of stimulation. And if you see the duration of stimulation, HMG is slightly more than that of recombinant. And there's a reason for it. Estradiol, again, was higher in recombinant than in HMG. Now, let's look at the key markers. And what are the key markers that will tell us whether we should go in for a fresh transfer or we go in for a frozen transfer? Is the level of progesterone. And the level of progesterone is higher in recombinant FSH. And in the past, we have mentioned this, that independently recombinant FSH in PCOS will give you a higher progesterone levels. Now, if you look at the number of oocytes, there's a significant difference in the number of oocytes, which with recombinant FSH giving a higher number of oocytes, a higher number of metaphase 2 oocytes compared to HMG. And if you'll see a, a, a significant, you know, marker in terms of, let's have a look at, I'll try and mark this up. And if you see this, and if you're going to see the number of oocytes and the number of M2 oocytes. So you clearly see that there is a huge difference between recombinant as well as HMG. Now, if you look at the blastocyst, again, the blastocyst rates there were more blastocysts because there were more eggs. But then let's come down to the key markers which will point towards quality. If you look at the excellent quality blastocysts, between both these groups were equal. So even though the number of blastocysts were less in the HMG group, the difference between the top quality blastocysts in both the groups were equal. If you again look at the aneuploidy rate was again very similar, 24% and 27% in both the groups. But let's look at the key markers. And the key markers would be the live ongoing pregnancy rate, which is 35% and 30% in favor of HMG. But per transfer, if you look at the fresh transfer rate, was higher in the HMG group. And surprisingly, with frozen embryos, the live birth rate was better in the HMG group. Now, I'll need to erase all this. So what do you have to say, Sachin? I'll just... Sachin?
Oh, yeah.
I'll go through.
So I feel the recombinant FSH basically got popularized because of its purity and no batch-to-batch variability, and obviously could be produced to the requirement of the population and the requirement of the fertility clinics. It got the popularity very fast as well. But what we realize, it definitely improves the numerically the oocyte number and the metaphase 2. And just because the egg number is high, the number of embryos created are high. But when it really comes to the blastocyst morphology or the excellent morphology, well, it wouldn't be of a great difference between an HMG HP and the rFSH. So I think this is a very important study because we need to tell the story of LH in women who are PCOS and who could be having a little high LH level as well. A subgroup of PCOS will have a little high LH level. Even in that group, these particular medicines, especially HMG HP, will be associated with a better blastocyst quality and hence a better pregnancy rate.
So I'll go to the last two slides, and this again tells us quite a stark reality of what's happening. So we look at the ongoing pregnancy rate per cycle started. Again, with the HMG, the success rate seems to be higher. The cumulative live birth rates, again, seem to be very similar. But again, the early pregnancy loss seems to be less with HMG. So what this study has come up with is, it shows HMG versus recombinant shows that giving HMG gives you a lower estradiol level. It gives a lower progesterone level on the day of trigger. Yes, it gives a lesser number of oocytes. A number of blastocysts were lower, but the number of top quality blastocysts were equal. The aneuploidy rate was similar. Higher ongoing pregnancy rates per cycle started. Per live birth rate per fresh transfer when it was done was higher, and live birth rate in frozen transfers were also higher. If you look at the ovarian hyperstimulation rate, significantly lower in terms of severe ovarian hyperstimulation. Also, in terms of all ovarian hyperstimulation, the risk was lower. And the important points which I have been able to gather from this is that when you use highly purified HMG, there are lower pregnancy loss in fresh and in frozen cycles. The question, which is quite surprising, is why would a frozen cycle there be a lower chance of pregnancy? And that's probably because of the embryo improvement in quality of the embryos which were
Pregnancy
preserved.
loss, you mean? Low pregnancy loss in uh,
Absolutely.
FE.
And it seems that even though you have a lower number of oocytes, you have the same number of top quality embryos. Even though, and the question which he asked is the frozen transfer rates were higher, even though the euploidy was known, which means that even euploid embryos with HMG seem to have a better implantation, and there was a lower incidence of excessive response. So what they concluded is in their paper is that in high responders, highly purified HMG treatment is consistently associated with moderate stimulation, lower incidence of complication, lower pregnancy loss, and a higher ongoing pregnancy in fresh or frozen cycles. And what this does give us is it gives us a chance to individualize treatments in the case of high responders. A, sh- a short paper, but I think quite a good paper to review and get the discussion started.
Yeah, I think this is a fantastic paper. But uh, Anil, if I think whenever we commonly use the terminology controlled ovarian hypostimulation or COS or controlled ovarian stimulation, but what are we really controlling? Don't you think we're not controlling anything there? And we should just call it ovarian stimulation. Because if the ovary just responds exponentially with a large recruitment and growth of the follicle, or continuous growth of follicle, and that's what typically happens with an rFSH usage. We literally have a wild stimulation rather than we can't tell a lady that, well, you're stimulated very wildly this time. So we use the term COH, but that control is something, the word doesn't have a great meaning when it comes to our practice. Secondly, so we need a control over OHSS. We need a control over maybe a large, we don't want a large number of cells and a large number of follicles, especially the small follicles, who could be contributing to the OHSS but not contributing to the blastocyst there. So I think this word controlled is makes a sense when you use HMG than rFSH in these women who have a AMH beyond 5 nanograms. Don't you think so?
No, I completely agree. I think it allows us to have a more moderated response. Mm, I don't know what in your setup, and I know because in India there is we have got limited number of HMGs, and they tend to be Meriofert and Menopure, and we have got two or three recombinant. And but in India, I believe there is a huge range of HMG, and how do you make the decision of what to use and what not to use?
I think that that's such an important point you raised, and we always face that dilemma. And I would divide the HMGs in India into two parts. One is the HMG HP, which is available from Ferring, that is Menopure, and the other is a large number of HMGs who basically get their raw material from various countries, right, from Argentina, Spain, Italy, China, Korea, etc. And a lot of time, the packaging of the lyophilized powders and the solvent is done in India and is distributed widely. Uh, when it comes to Menopure, I went through one paper by, I think it's a paper by Vergam et al. It was published maybe about 10 years back. And they literally went through the procedure wherein they described that at the donor, where the urine is taken, at that menopausal urine level itself, the donors are much better screened. And they take about 1 lakh donors who are totally screened donors, and then the urine is collected. And secondly, the purity of the FSH molecule is high because they go on doing a lot of methods of chromatography wherein the FSH purity is high. And when you purify the menopausal urine to get the FSH molecule, the LH is eventually lost. So they get a very highly purified FSH, which is very similar to that of an rFSH, though not as less acidified as that of rFSH. But in the you do lose on LH, but then intelligently the LH is replaced by HCG. It's about 9.9 IU of HCG, which corresponds to about 70 to 75 IU of LH activity. And HCG and LH are two different molecules there. HCG has a long acting there. It acts for about 24 hours or more, while LH is a short acting. So if you want to give a consistent LH support with rFSH, many times you may have to use two doses of LH, RLH. Well, with Menopure, it doesn't happen so. You have an HCG there, which will act with one single dose. And secondly, the receptor activation with HCG is more steroidogenic. So you get a nice progesterogenic phase and you have a better endometrium and a better implantation rate. While with RLH, it is an ERK1 and ERK2 pathway. So they say the maturation of the oocyte is more. And that probably, though in this particular study, they have not used RLH. So we can't have the comparative arm in that particular fashion. So I would rate when it comes to HMG, HP, Menopure as my brand in India, because that makes it. Though no, I'm not getting directed by the company. I'm not biased about it. But let me tell you that Menopure, though expensive, makes a huge sense to me because it has a better FSH purity and HCG as a replacement of an LH activity there.
Yeah. We have two highly purified HMG here, and one is Meriofert and Menopure, and both of them derive their LH activity from a certain about 9 to 10 units of HCG, and both seem to get very much the same results. So, and also the additional part in the UK is that almost all the drugs approximately cost very much the same. There's a slight difference, though. In many other countries, there's a huge difference between HMG and recombinant, and that does not happen in the UK. And the drug cost very much borders around the same. The second thing, which and I know we spoke about it in our course, and is I believe that having LH activity early on in stimulation acts as an antagonist, which means that if you look at the follicles which are large, which tend to start recruiting faster, and these are follicles which are 8 to 10 millimeter, or in fact more than 6 millimeter, they get recruited with HMG and FSH. But the smaller follicles, which are this, will start coming closer to the second cohort, which are also the cause of persistent OHSS, or rather prolonged OHSS, are not recruited by HMG at all, because they're as an antagonist, HMG knocks them off.
Yeah, that's such an important point to decrease OHSS and not the small follicles come down.
The other thing which is very important is that if you're planning a fresh transfer, and I think what tends to happen is in many countries, freezing of embryos is not at its best in certain clinics, and it's very important that your embryologist should be able to get a very similar result on freezing as much as in fresh transfers. And those laboratories where there's very good freezing, and I think freezing of embryos becomes a choice. If you're going for a fresh transfer, then it would be easier, and in fact, you'll give a better result if you are able to add certain amount of HMG rather than recombinant FSH. And I think, especially in countries like India and the rest of the subcontinent, there's variability. Some clinics are phenomenally good, and in fact one of the best in the world, while some clinics will go for batching and depending on embryologists coming from elsewhere.
Yeah, I think you clicked the right chord there. So most of us in India, in a patient who is a high responder, typically do an antagonist cycle, number one. Number two, they would be giving agonist trigger so that they don't face OHSS, and it's a self-funded IVF, it's not an insured IVF. So we do worry a lot about OHSS, and one of the mottos is to have a zero OHSS clinic. So therein, most of our embryos are going to be frozen, and we will be highly dependent on the FET cycles. So if this trial is proving beyond doubt that even in the FET cycle, the pregnancy rate with HMG-HP is much higher than the rFSH, though we are transferring less number of embryos there. And when time to pregnancy is also better. So somewhere, Anil, let me just compare this paper to the Richard Legro study of letrozole and clomiphene citrate, randomized study which was conducted then. And this was one of the largest randomized studies, and which proved to us that letrozole is a better drug than clomiphene citrate, especially in obese PCOS. It may not be of a great significance in a lower weight PCOS, but especially in obese PCOS, it is no doubt that letrozole is much better. And that really changed the whole practice of our practice of ovulation induction. Well, this paper is doing something very similar for our practice of ovarian stimulation in PCOS. It is giving us a clear direction that you don't want OHSS, use HMG-HP. You want to have best quality blastocysts, use HMG-HP. You want to do fresh embryo transfers, well, use HMG-HP because the fresh embryo transfer pregnancy rates are high. Even if you're doing FET, well, your blastocyst qualities are better, the cryosurvival is better, and hence your pregnancy rates are better. So I think it's giving a clear-cut direction. Whatever may be the LH level, whatever may be the AMH, whatever may be the severity of the PCOS, HMG-HP is the way to go ahead. Now, one more thing, many times I've seen, since you raised this question about batching, a lot of people, not just in India, I'm sure all over the world, people must be batching and they'll end up using OC pills treatments. And what the science tells us, and there are some funny people use funny protocols wherein they give antagonists to start for 4 or 5 days and then they start with stimulations and something like that. So by giving OC pills and antagonists, they're using a lot of GnRH agonist stop protocol also. With all these protocols, though these protocols may not be very common in PCOS, I do agree, a lot of PCOS will be taken new. But whenever you do these protocols, you are going to suppress your LH activity. And then you use only rFSH alone. When there is no pool of LH available for a good oocyte maturity, you're going to suffer. And your follicle output rate at the end of the trigger. And if you're using to prevent OHS, you're using a GnRH agonist trigger. We all know that the productivity of the GnRH agonist trigger is highly dependent upon the LH level you start with. And if you suppress your LH level by using these agonist or antagonist or by OC pills, obviously your follicle output rate at the end of the trigger would be less. So I have a feeling we should be, 1 minute. We should be using HMG-HP whenever we are giving any kind of pre-treatment. Well, that's what it would make a difference too.
Okay. Well, anything else you would like to add in terms of
I think one more thing is, if you go through this materials and method, they have used a very humble dose of 150 IU. I think most of you in the Western world could be also using 150 IU for your polycystic ovary. In India, I would say 50% of the consultant would be using 150 IU, but most of others could be using a dose of 225 and sometimes even 300 IU. So using such high doses, because they feel that more the merrier, you get just more number of embryos and more blastocysts, and then you would do better off. You can do multiple cycles. But then with even using 225, you're going to have a higher stimulation. And using rFSH, your chance of OHSS and all that would definitely go up again. And your chance that you will be doing a fresh embryo transfer will just go away. So I think humbler we go with a dose, use of HMG-HP would be, and even with a higher dose, it would be beyond doubt an HMG-HP as a choice of therapy than rFSH.
But equally, I think it's so important to be able to head towards stimulation, knowing your FSH threshold is giving an idea. And people forget that there are many components that head towards FSH threshold. You're looking at ovarian size, antral follicle count, AMH, LH. And I think that will give you a fair idea if a dose of 150 is going to work. And it is no doubt. Sometimes I'll move to a higher dose because knowing that we will not be able to break the FSH threshold. But I agree that I think first and foremost, our aim should be to make this treatment safe, and that is lowering the chance of even hyperstimulation, which is life-threatening.
Yeah. So let's revise one point, Anil. So suppose I ask you, what is the inference you draw when you see a high LH PCOS? What goes in your mind when you start this ovulation induction or ovarian stimulation for a high LH polycystic?
No, I've got this chart which I grade from green, amber to red. And red basically tells me that it is ovary that's difficult to stimulate. And you see that in LH levels skyrocketing, AMH levels skyrocketing more than, let's say, 7 or 8 nanogram per ml. Antral follicle counts which are small. And I believe that small follicles have more AMH, have more resistance. FSH that is on the lower side of normal, which is about 2 to 4. And again, which means that the impact of FSH is still limited and it's not very good. And these ovaries just don't budge with 150. And I think you can anticipate these ovaries going to give you a certain amount of trouble. And I think it's important to have the discussion. And often what I'll tell a patient is I'll say, I'll give you 150 for 5 to 7 days and let me see your response. If I see a poor response, then I would prefer canceling the cycle and recounseling and saying I need to go down in a step down protocol. But equally, it's important to know that some of these ovaries which are having a very difficult PCOS may be very sensitive to gonadotrophins. So trying to rush on a higher dose is risky, and you may, even at the dose of 150, recruit 20 to 40 follicles. So starting lower, reassessing it, having a very fair discussion with your patient to know, say, well, your ovary just may not stimulate. I think it's very important before you proceed on a high dose.
Yeah. And what about your ovulation induction or IUI cycle? Do you think just going through the study of HMG, HP, and rFSH in IVF, uh, we expect a similar thing in IUI, wherein you would like to go, because IUI is something you are going to go by HCG only. It does not give you the liberty of using GnRH agonist as trigger. So would you like to go for with HMG, HP there more commonly than rFSH?
I don't think there are any studies which have looked at the success rate of IUI versus gonadotrophins. They've looked at
Yeah.
gonadotrophins versus clomiphene and versus letrozole. So it's very much, I don't think I have a preference towards it. Recombinant is easier to administer, and I tend to use recombinant for intrauterine insemination. And at a dose of around 50 to 75 of recombinant, we tend to achieve between 3 and 1 follicle. And I don't know. I don't know whether in IUI using HMG improves the chance of success. I don't know what's your thoughts about it.
We use HMG for the economical reasons as well. So, if the whole cycle cost comes down. So, but then I've been using Menopure. I use 75 IU Menopure in a go low, go slow protocol. I'm very happy about it because my stimulations are much more controlled, and a target of just getting 2 eggs and 3 eggs becomes much simpler. And but in India, we also use letrozole and Menopure. So you do use sequential therapies, which is not so common in the Western world.
Yes.
But now, just going to when we look at this HMG HP, again, time and again, over the last 2 decades, the various popularized trials, like as I remember this trial with P. Diamond et al., or the Amigos trial, I think they use HMG HP. There was one trial of using HMG in IUI compared to conventional IVF and single embryo transfer compared to minimal stimulation IVF. There also they use HMG HP. You going back to Alinani's meta-analysis, which has been published in 2007 and subsequently 2011, two-thirds of the patient who already used in those trials also HMG-HP was Menopure, and which was associated with better live birth and less miscarriage rate. So this story of having better live birth and less miscarriages with HMG-HP we are hearing time and again with all the major trials, and this Megaset HR is probably just signing it again.
So that was it was a nice paper, and I think it's the starting of one of the series of that we'll plan to do in the next bi-weekly, and then let's see how this thing goes. But thanks a lot, Sachin. I think it was
Yeah, thank you.
quite
It
brilliant.
was an interesting paper to discuss. Thank you so much.